today's class will be on the infections, staphylococcal infections, if time permits, streptococci, and also the gram-negative infections. They are the most earliest human pathogens identified. It normally colonizes the skin and the mucous membranes, and they enter into the, especially the foreign materials, especially the soil, plastic cannulas, prosthetics. If they are the present, they enter into the bodies as a commensal organisms. They are non-motile, non-sporulating. They are gram-positive cocci, very small in diameters, either singly or in the pairs, short chains. It looks like the grapes. So that is the reason in the Greek word, staphylo means grape-like. They are irregular three-dimensional clusters. These are staphylococci. Two types, coagulase positive and the coagulase negative. Coagulase positive are very virulent. They can clot the plasma, more virulent. There are about 6 recognized species, and the most common is the Staphylococcus aureus. Coagulase negative, they cannot clot the plasma. They are less virulent. Staphylococcus epidermidis, especially involves the prosthetic materials. Important nosocomial pathogens. And the compromised hosts like HIV positivity or chronic uncontrolled diabetes, elderly, etc. And the Staphylococcal saprophyticus that involves that causes urinary tract infections. So these are the two main subsets of the staphylococci. One is coagulase positive and then one is coagulase negative. They cause superficial and the deep pyogenic infections. As they are very virulent, they may cause systemic intoxications, and most of the urinary tract infections as a coagulase negative Staphylococcus saprophyticus. Staphylococci is the leading cause of the bacteremia and sepsis. Mostly it involves the surgical wound infections, infections of the bioprosthetic materials. Very leading cause of the nosocomial infections, especially in our ICU setups. And it also causes the bacterial food poisoning with the preformed toxins. We will move on to the aureus. These are the common sites of the colonization. The mucous membranes of the anterior nasopharynx, axilla, vagina, skin, and perineum. It causes two types of the syndromes, one by the intoxications and the second one by the infections. So the toxin can be produced in vivo or in a suitable vector. So in vivo as in toxic staphylococcal syndromes or staphylococcal scaled skin syndrome 4S, or in a preformed toxin, as I told you, it may cause the food poisoning. So staphylococcal food poisoning. The earlier one is intoxications, where the toxins. Here they are the infections. They involve the bacterial proliferation, invasion of the destruction of the host tissues, local and the systemic inflammatory responses by the host to these events. So what is the pathogenesis? One is the most important is the colonization by this toxigenic strain of the bacterium, toxin production, absorption, and later intoxication. So this depends on the individual's opportunity. The invasion of the bacterium across the epithelial and the mucosal barriers, adherent to the materials in the extracellular matrix. Then there will be the evasion and the neutralization of the host defenses. And finally, the destruction of the host tissues. So they are the products of the Staph aureus which alter the host environment. So the coagulases, lipases, and hyaluronidase. Coagulase, they bind the prothrombin, then the conversion of the fibrinogen to the fibrin, protection from the cells of the immune system or from the antibiotics. Lipases, they enhance the organism's survival in the subcutaneous areas, sebaceous areas of the human body. Hyaluronidase facilitate the spread of the organism through the extracellular matrix to the adjoining tissues. So these, they alter the host environment, especially the coagulases, lipases, and hyaluronidase. Other enzymatic products, these are staphylokinase, thermonuclease, and serine protease. The membrane active toxins that contribute to the pathogenesis by damaging the host cells. Alpha, beta, and gamma hemolysins. Synergohymenotrophic toxins, mostly the hemolysin or the valentine leucocidin. So you need not remember all these things, but the pathology of the Staph aureus is very, very dangerous because it's a very common cause of our nosocomial infections, and left untreated, it may go into the toxic shock syndromes also. So these are all the pathophysiological mechanisms by which it causes the damage. So the clinical features may be due to the toxin or maybe due to the infection. So staphylococcal food poisoning is very, very common. A skin syndrome, bullous impetigo, very often we see in our OPs, scarlet fever, and finally shock syndrome. There are different organs involved in these infections, mostly the skin. You can see the furuncles, cellulitis, especially in the diabetic individuals, impetigo, carbuncles, again in diabetic individuals. So these are very, very common skin infections caused by the Staph aureus. In the lungs, pneumonias, lung abscesses, bronchopneumonia, etc. In the heart, it could be pericarditis or endocarditis with a lot of the vegetations on the valve areas. In the central nervous system, mostly the meningitis and sometimes the brain abscesses, raised intracranial tensions, maybe the death is also there because of these uncontrolled brain abscess and the meningitis, and maybe thrombophlebitis, vasculitis. These are all very common. Bones and joints, osteomyelitis and arthritis, mostly we see in ortho-OPs, ortho-wards. So a lot of the people, they are infected post-operatively. So it's all because of the staph causing osteomyelitis and arthritis. And others, septicemia, enterocolitis, pyomyositis, parotitis. So these are all very commonly seen by the physicians. So all these infections. The same thing here, if you see the brain, CNS, the meninges and abscesses, bone and joints, osteomyelitis, septic arthritis, intestinal infections, the enterocolitis, multisystem toxic shock syndrome, skin, the wound infections, boils, styes, carbuncles, abscesses, furuncles, cellulitis, etc. In the bloodstream, there may be the bacteremia, septicemia, sepsis, cardiac, pericarditis and endocarditis, and respiratory, pneumonias, abscesses, lung abscesses, empyema. So this is the toxic shock syndrome, acute, life-threatening intoxication, characterized by the fever, hypotension, rash, and multi-organ dysfunction. So this is the toxic shock syndrome. The fellow is febrile, is in hypotension, a tachycardia, hyperapnea, and there may be oliguria, and then may be the jaundice. So there are the multi-organ dysfunction. Desquamation during the early convalescent period. It's caused by any of the several related exoproteins produced by the Staph aureus. TSST1, that is the most frequently implicated the toxin, causing virtually all the menstrual cases. Staphylococcal enterotoxin B is the second most frequent cause. This toxic cephalosporin syndrome, that illness to develop, an individual must be colonized and infected with a toxigenic strain of the Staph aureus. Mostly it is by the coagulase positive Staph aureus. Coagulase negative Staph, they won't cause a toxic shock syndromes because that is not that virulent, but this Staph aureus is very virulent. Lack of the protective level of antibodies to the toxins made by that strain is primarily a disease of the young people that reflects the fact that more than 90% of the adults have antibodies to the TSS toxins. So mostly the menstruating women use of the barrier contraceptives during the childbirth. In non-menstrual TSS can injure after superinfection of the skin lesions following the burns, insect bites, varicella lesions, surgical wounds, post-operators. Onset is very acute, presents with the high fever, nausea, vomiting, abdominal pain, diarrhea, myalgias, sore throat and headache, dizziness as a feature of hypotension, orthostatic or frank hypotension, macular erythroderma develops over the first 2 days of the illness, rash, you can see that, conjunctival suffusion, pharyngitis, and a strawberry tongue in most of the patients. So these are all the features of the toxic shock syndromes. See the rash on the legs due to the toxic shock syndrome. See the erythema of the bulbar conjunctiva, facial erythema and edema. See the cutaneous manifestations with osteomyelitis and see the skin of the hand. See the disc formation after the toxic shock syndrome, full thickness disc formation. These are common abnormalities we often see in these cases: azotemia, hypoalbuminemia, hypocalcemia, hypophosphatemia, creatine phosphokinase elevation, leukocytosis or leukopenia, thrombocytopenia and pyuria. Late sequelae, they may cause peripheral gangrene, reversible nail and hair loss, muscle weakness, severe asthenia, and sometimes neuropsychiatric dysfunctions. So this is the diagnostic criteria for staphylococcal toxic shock syndrome. Usually fever will be more than 1 or 2 degrees, rash usually after 48 hours, a diffuse rash, a macular erythroderma, disc formation, so 1 to 2 weeks after the onset of the illness, particularly the palms and the soles, hypotension, systolic less than 90, involvement of the 3 or more of the following organ systems, maybe gastrointestinal, so nausea, vomiting, muscles, myalgias, mucous membranes, hyperemia, and the renal, azotemia, hepatic, maybe jaundice, hematological, either neutropenia, leukocytosis, or thrombocytopenia. The CNS, maybe the meningitis, RAPS, etc., or pulmonary, like adult pulmonary respiratory distress syndrome, ARDS. So Staph aureus infection or the mucosal colonization. So these are all the diagnostic criteria for these things. So a lot of the things will be present in our cases. There will be fever, there will be multi-organ involvement, and there will be disc formation and hypotension. So always think of one of the DDs as toxic shock syndromes. Severe febrile exanthem with hypotension. We have the few DDs here. It could be streptococcal, staphylococcal scald skin syndrome, Kawasaki syndrome, Rocky Mountain spotted fever, leptospirosis, meningococcemia, gram-negative sepsis, severe drug erections, exanthematous viral syndromes. So most of these are common in our areas except the Kawasaki syndrome and Rocky Mountain spotted fever. Okay. So streptococcal or staphylococcal skull syndrome, leptospirosis, meningococcemia, gram-negative sepsis. So they are all very common DDs in our setup. Both staphylococcal or streptococcal can be clinically indistinguishable unless you see the histology wise. So the treatment, drainage of the site of the toxin production, aggressive fluid resuscitation, so the fluid balance as they are presenting in hypotension, good antibiotics, especially the penicillins or erythromycin or zithromycin or clindamycin. Okay. And surgical wounds should be explored and irrigated. Foreign bodies should be removed. Pressure should be used for the sustained hypotension that is unresponsive to your IV fluids. And electrolyte abnormalities, especially hypocalcemia, hypomagnesemia, so they must be corrected. So the picture is IV fluids, good antibiotics, and correction of the electrolytes. So penicillin-resistant penicillins like oxacillin, first generation cephalosporins, they are very, very effective. Clindamycin, vancomycin, when you are dealing with a methicillin-resistant Staph aureus, MRC, so the drug of choice should be the vancomycin. And usually you have to give about 2 weeks therapy of these toxic syndromes most of the times. Sometimes immunoglobulins contains high levels of the neutralizing antibodies to your toxins. Indications here, they warrant the vasopressors who require mechanical ventilation, who have worsening of the renal function, or undrainable focus of the infection, where immunoglobulins may help those individuals. Otherwise, with IV fluids and with your IV pressors or your electrolyte imbalances and with your cephalosporins or penicillins, if the patient is getting relief, so there is no need of the immunoglobulins. So in spite of all these measures, still the patient is in hypotension, still the patient is not responsive, the patient is in oliguria, so then you can use of these immunoglobulins. A single infusion, 400 mg per kg, generates a protective level of antibodies to this toxic staphylococcal syndromes, one that persists for the weeks. Glucocorticoids role, they have not shown any significant benefit. So this is the staphylococcal scald skin syndrome, 4S, that encompasses a range of the cutaneous diseases of varying severity caused by the exfoliative toxin, producing the strains of the Staph aureus. Here the toxin is exfoliative toxin, ET. It is the most severe form, like Richter's disease in the newborns, toxic epidermal necrolysis, 10 in older individuals. So if you touches the skin will attaches to your hand. Very bad. Mild and more common forms, the pemphigus neonatorum and bullous impetigo. The rarity of the syndrome in adults has been described to acquire immunity to the inciting toxins, enhance the renal clearance of the toxins, diminished sensitivity to the action of these toxins. So these are all ET, enterotoxins. Again, this is also an acute, a sudden onset with rash. So the rash usually appears along with the acute presentation. Begins in the periorbital and the perioral areas, the rash, spreads to the trunk and centrifugally to the limbs. Pastias lines, they may be apparent. They are the petechiae and the body folds. Skin sandpaper texture. So these are the features of the 4S. So acute presentation with the rash mostly in the periorbital and perioral areas. So in the face, then it spreads to the trunk and to the limbs then. So there may be the petechiae in the body folds and the skin is sandpaper texture. Within hours or the days, wrinkling and sloughing of the epidermis begins. Sloughing can be provoked by the gentle stroking of the skin. So this sign is called Nichols kiss sign. These areas are very red and glistening, but not the purulent. So erythematous will be there, but not the cellulitis like picture. Large bullae, significant fluid and electrolyte loss can occur at this stage and secondary infection. Within 2 days, the exfoliated areas dry and secondary disc formation begins. The entire illness resolves within about 10 days. So this is the 4S. See the picture, the skin. Administration of the anti-staphylococcal agents like mostly the penicillin antibiotics or cephalosporins, fluid and electrolyte balance, and local care to the skin. So Staphylococci then also cause the skin infections, mostly the folliculitis, furuncles, and carbuncles. The folliculitis, they are very superficial, involving the ostium of the hair follicle, or very deep. If it involves the very deep, they are furuncles or the carbuncles. See the linear streak extending from the wrist to the upper arm. So this is the acute lymphangitis. So the infection spreads from the portal of entry within the superficial lymphatic vessels. Portal of entry of the infection is seen on the lateral thigh with the necrosis of the skin. Infection is extended mainly proximal from this side. So this is the bullous impetigo. Scattered, discrete, thin-walled vesicles on the bullae easily rupture and form the erosions on the thigh. So earlier one is the bullous impetigo. This is the non-bullous impetigo. And this is the folliculitis, pustular folliculitis. See the numerous superficial erythematous papules and the crusts of the hair follicles in the beard area. See the furuncle over the cheek, close to the nose. A painful abscess with associated facial edema. So typical carbuncle on the nape of the neck, sometimes the paraspinal areas. A large inflammatory plaque studded with the multiple pustules, some of which have ruptured, draining the pus on the nape of the neck. See the carbuncle. Here an abscess over the heel, a very tender abscess surrounding erythema on the heel. Deep folliculitis is the furuncles and the carbuncles. A simple folliculitis is a superficial one. So here infection caused by the Staph aureus, but can also be caused by the physical like traumatic or chemical injuries. Staphylococcal folliculitis is most common in the children and occur on the scalp or the limbs. These heal in about 7 to 10 days, but can become more chronic, and in older children and adults can progress to the deeper form of the folliculitis. The deep folliculitis, males are more common. Body side can be affected, but it is the neck, buttocks, and anogenital area. Predisposing factors include the tight clothing such as the neckties. And in India, most underlying cause could be diabetes. They start as an inflammatory nodule. They become pustular and fluctuant and is often tender. Associated with the constitutional disturbance, They rupture to discharge the pus, and they are very deep, and they leave a scar after healing. They can progress to form a carbuncle, which implies the involvement of the several contagious hair follicles. Middle-aged men and conditions such as the diabetes or immunosuppressive therapy, they predispose to it. It is an exquisitely tender nodule, carbuncle, over the neck, shoulders or hips, and associated with the severe constitutional symptoms like fever, nausea, vomiting, etc. So the 4S again here, a potentially serious exfoliating cutaneous disease, occurs predominantly in the children, particularly the neonates. Clinical manifestations are due to the protease-like effect of the exfoliative toxins from a focus of the infection to Staph aureus. These exfoliative toxins A and the B specifically cleave the desmoglein 1 present without the desmoglein 3 in most superficial epidermis. These are mostly the children's Staph aureus. So the immediate introduction of the appropriate antibiotics like your penicillins or cephalosporins or cloxacillin, they supportive measures in a high dependency unit if needed, they are very important. Sometimes no, debridement is also needed here for large carbuncles. Bacterial swabs from the carrier sites, the nostrils, the axilla and the groin should be taken from the patient's relatives to exclude the staphylococcal carriers. See the wound infection. So the typical staphylococcal wound infection. Here the cannula related infection. Skin abscesses and the metacarpophalangeal joints here. Another one or the wrist area. See the skin, palm, full thickness desquamation after toxic shock syndrome. So this is something about staphylococcal infections. So very common in our routine practice. So your follicles, your carbuncles, okay. Sometimes shock syndromes, these are very common.